Yes, thank you, thank you. Well, first off, thanks for the team for having me here. This is a topic I'm really passionate about and really excited to talk to you live and the group here on Facebook Live. So thank you for weathering the heat and coming out. So we're going to chat a little bit about falls, how we prevent falls, what we can do to identify some risk factors for falls, and both intrinsic factors, extrinsic factors. We'll define all these things. Before we do that, just a little bit of an introduction to who's talking to you today. My name is Brandon Girardi, like Brian said, a PT. I've been working in the West Michigan area in operations and in patient care for the past 16 years. Graduated with my undergrad degree from Grand Valley years ago, another bachelor's degree from U of M Flint, and I got my doctorate in physical therapy from U of M Flint in 2008. Pictured here, my daughter, Adelina, she's a little 8-year-old. Keeps me running around. It keeps me young. And my wife, Emily, who's a PA in town. Outside of work, I love running marathons, run a few a year. I do a lot of paddling, flat water marathon paddling. So gearing up for a 120-mile race next month. Hopefully it's not this hot. But some of my happy places on the water, whether I'm training or racing or whatever we're doing. So we're going to get into a little bit of interaction here. Show of hands. How many of you know someone who's suffered a fall? Okay. How many of those people's lives were changed because of that fall? How many of you here are afraid of falling?
Everybody's afraid of falling. That's a silly question.
You're right. You're right. Has anybody here suffered a fall? All right. Well, we have an active audience here of individuals who hopefully we can take some things away from this. Anybody here had their life changed in some way, shape, or form? All right. So we're going to get into a little true and false just to check into hey, we're going to be grading these tests later. So true or false? Falls count only when you hit the ground. Correct. That is false. Yep. Any surface that we're falling onto that's a supporting surface, a chair, a wall, a couch, we'd consider that a fall. True or false? Falls are a normal part of aging. No. False. You're right. True or false? Falls are preventable. Yep.
Oh, yeah.
Very good. Awesome. All right. So before we jump in, let's define what falls really mean. So like we just chatted about, a fall is anything that's an unplanned event, right? It's something that's unexpected, falling onto a supporting surface. That could, like I said, be a wall, a chair, anything like that. We would not define a fall as something where somebody's being pushed or a medical event like fainting, things like that. That we'd categorize that slightly differently. If somebody were to have a cardiac event, right? Their primary diagnosis would have been that cardiac event as opposed to somebody who's tripping over a rug or somebody who tried to stand up and didn't have the strength. We'd treat those in different ways. So what we'll focus on here today is going to be kind of the falls that would not necessarily be because of underlying pathology. We'll touch a little bit on that. And maybe if there's questions specifically, we can get into that in a little bit. So I think to understand where the biggest risks are, we have to think about the demographics of who would be at the greatest risk of having falls, when they would most commonly occur, why they would occur, how often they would happen, and also learning about the factors that would contribute to fall risks. So I'm going to bore you with some statistics here for a little bit, but I think it's relevant to think through the scope that this has on our lives, the lives of those around us. So fall prevention is one of the top 10 federal health priorities through Healthy People 2020. And the CDC recommends that anybody over the age of 75 receives a fall risk assessment. So don't take it now, but in front of you is a fall risk assessment that I'll have you take home. And this is going to give you a little bit of a jump start on identifying areas that we may be struggling to some extent. Injuries related to falling is the leading cause of accidental death in people over 65. So it's not a small problem. It's a problem that affects the lives of many of us, whether it's friends, family, ourselves. nearly a third of healthy adults over the age of 65 had a fall every year, and nearly 1/3 of those falls result in a serious injury. So it's something in my clinical practice that I take really seriously, because not only do I see falls themselves being a problem, of course, but I also see that fear of falling completely taking people out of their normal rhythm of life, interacting less with their friends and family. I think about community events like this, even, that somebody may think twice about attending because they're fearful. They don't know the way in or through a building, and they get fearful of what could happen. So it kind of becomes this vicious cycle where people wind up becoming less active in their day-to-day world, interacting less and less with family, leading to a decrease in quality of life. And 3 million older adults are treated in the ER every year because of falls. So the impact of falls: every year, 300,000 Americans suffer from fall-related fractures. Every week, 250 Americans die, every week, 250 Americans die from complications due to a hip fracture. Those complications could be pulmonary embolisms, infections, cardiac-related injury or issues when they're not able to be as active as they need to be. And every day, more than 400 Americans suffer permanent loss of mobility because of falls. So this could be a fall resulting in impact of a countertop. Falls in bathrooms are always scary because everything's hard and everything's close. So it's hard to not have an impact to something if you're having a fall in some of those environments. So consequences of falls. So hip fractures, loss of mobility, big things that I see that that may be less obvious, like fractures and the loss of mobility, depression. When people are unable to do the things that they want to be able to do, or people are fearful to do the things they want to be able to do. Arm injuries, of course, when we're catching ourselves falling, and death because of those falls, whether it's a primary issue because of the fall or a secondary issue. So the impacts of independence: half of people with hip fractures do not go home and live independently after hospitalizations, which is incredible to me. The amount of individuals that would have hip fractures. We talk about the older population, and we factor in osteoporosis, we factor in other arthritic or bony related issues, and people are more likely to have fractures with falls. 20% of people who suffer a hip fracture following a fall will die within 1 year of that fall. That's contributing largely to secondary immobility, being less active, more cardiovascular issues, more issues potentially with infections, blood flow issues, things like that. And since 2000, the death rate from falls has doubled, which is staggering to me. Falls were the cause of 80% of hospitalizations due to injury in Michigan, which again, these numbers are kind of staggering. So show of hands. When we think about falls, we kind of define it that way. Is it what you thought it would be? Kinda.
Tripping over your dog and hitting ground.
That's exactly it. Yeah. And we're going to get into some of those factors. We'll get into some of the intrinsic and extrinsic factors. Intrinsic factors being things like strength, etc. Extrinsic factors being the dog. Is that how you had a fall?
Yeah.
Over a dog?
Yeah, one of the grandkids.
There you Yep. How old was the grandkid? 3, ran right out in front of you.
Well, I was playing ball with the other 2 older ones, and I was backing up quick, and he's kind of walked in behind me, and I was going to knock him down, so I jumped over him.
Yep.
Backwards.
Yep.
I thought I was going to land on the grass, and I landed on the sidewalk.
Oh, no. Somebody record it?
No, but I remember coming to an hospital.
Oh, my goodness. Not good.
Your head?
Oh.
Close hit injury, and I wound up with a torn retina.
Real belly.
So we talk about the secondary factors because of falls. That's why you had the nod going on there. You've experienced it firsthand. Yep, and those things happen so fast, right? It's hard to predict those things. So does the prior discussion change your answer as if you've fallen in the past? If we change the parameters of not necessarily having to hit the ground thinking about kind of a stumble onto a couch, things like that. You think about falls a little bit different?
Yeah.
All right. When you fell, of course you told your primary care provider because there was a whole team of people helping you. Right. But has falls been brought up in any of the conversations that anyone else has had with their physicians? Okay, good. All right. Did you know a previous fall increases your future fall risk? We'll get into that here in just a minute. All right, so here's some good news. So in front of you is that comprehensive fall risk assessment. And just by identifying some of the factors that can lead to falls can significantly help to reduce your fall risk. So again, you don't need to fill this out now, something I'd encourage you to take home and do and think through. And actually something that I'd probably have as part of a conversation when you're following up with your primary care physician next time you have a dialogue with them. I think it's good to identify anything that could potentially increase the risk of falls. So when we understand the risk, again, we're talking about those intrinsic and extrinsic factors. So when we think about intrinsic factors, age, a history of falling, a awareness of fall risk, comorbidities. So this could be neuropathies. It could be psychosocial issues if people had cognitive problems that weren't allowing them to interact with their environment the way that they wanted to. Vision problems, hearing problems, the postural hypotension, meaning I'm going from a seated position to a standing position. I do that really quick. We get the lightheadedness. Oftentimes that lightheadedness is a little bit delayed, so we get a step or two away from what we stood up from, and here we go. It can cause a lot of that dizziness. Vision deficits. Especially at night when people are getting up, if they're using the restroom at night, things like that, and they're not knowing if they're tripping over something. Hearing deficits, if they're not hearing the dog running up to them, or they're not hearing things that are going on around them, or not hearing it until they're startled and then trying to make a really quick movement. The nutrition and hydration status, that's one that I don't think we think enough about, especially days like today. You know, I moved 19 yards of mulch last night in 90-degree heat, and there got to be a point where I'm like, I got to sit down. And part of that is hydration, the heat, all times that it gets a little bit scarier. More intrinsic factors, strength deficits. So this is something that I see a fair amount is a patient will have some type of an injury. It could be hip pain, ankle pain, back pain, which kind of takes them out of their normal rhythm of activity. They try to get back into that normal rhythm of activity, but they don't have the same strength. I see this a lot after not even prolonged hospitalizations, but hospitalizations just for brief amounts of time. And people don't come home with the same strength that they had, but they come home to the same environment and the same tasks and the same habits. And somebody bends over to take a dish out of a dishwasher and they don't have the strength to get back up in the same way, or they're trying to pick something up from the floor, they squat down and don't have the strength to get back up. And the problem is they lost some strength through that event, whatever it may be. This could even be cold and flu season and we lose a little bit of strength. Range of motion of specific joints. If we don't have good knee range of motion, hip range of motion, back range of motion, ankle range of motion, it doesn't allow us to move freely in the way that we need to be able to interact with our environment the way that we otherwise would. Gait or walking patterns. So if somebody has ankle weakness, knee stiffness, hip stiffness, it's going to change the way that we're walking to some extent. I have several patients that have had ankle fusions or ankle surgeries, and they're catching their toe on cracks in a sidewalk. So their gait pattern would predispose them to having some of these fall-related issues. We think about activities of daily living and having disability or inability to do their normal tasks would be an intrinsic factor. We mentioned cognitive and attention deficits, urinary incontinence, when people are trying to get to the bathroom fast and they're moving quicker than they otherwise would want to, and peripheral neuropathy, whether it's a primary condition, whether it's associated with diabetes, where we don't have that same sensation. That can significantly change somebody's gait or their ability to balance is when we're on the floor, our foot's constantly trying to adapt to the floor, the ground that we're on. And sometimes with peripheral neuropathy, you don't feel that. Sometimes you don't feel it at all. I've had patients that have had, they've taken they're golfers and they took their golf shoe out of a golf bag and they put their foot in their shoe and their foot fit really tight in there. And they actually had a golf ball in their shoe and couldn't feel the golf ball that was in their shoe. And they're trying to cram their foot in there. So imagine the changes as you're trying to move through the community in different ways, and you don't feel your feet in that way. So when we think about a fear of falling, this is kind of the cycle that we talked about here a little bit. So somebody has a fall, which develops a fear of falling. Welcome. They have a fall, they have a fear, they develop a fear of falling. Therefore, they develop kind of a fear of moving in general. So they have a decreased activity level. They create that weakness. That weakness creates more propensity to having falls. We kind of get this vicious cycle. So the way that people typically will break that cycle in my clinical experience is start removing things that they like doing from the list of things that they do. So the cycle kind of perpetuates itself. And not really knowing where to start, oftentimes people just they would maybe blame their age. That's something I used to do. And I'm full believer that a person in motion stays in motion, right? So whatever that level of function is, let's be functioning at the top of your your functional level. Sounds like that might be a motto that you live by. A person in motion stays in motion.
Yep.
I thought the radio stick still working.
I love it. But that's part of it, right? And that's right for you. I can see the smile on your face. It might not be right for everybody, but it's right for you.
I don't think we have a choice.
So think about it. So intrinsic factors are things that have to do with us, right? Our range of motion, our cognition, more inward facing things, our pathologies. Extrinsic factors would be other things that are happening around us. So shoe style and fit. Sometimes I'll see people that'll come into the clinic and they're in their flip-flops or they're in something, footwear that isn't really good for them to be in. There's not the perfect shoe. So if you were to say, hey, what's the perfect shoe for me to be in? That's a loaded question. There's a lot of variables to answer that question. But being in the right shoe style with the right fit for the activity that you're doing is really important. Using an assisted device, this is one that gets me a lot with patients, because I think a lot of times patients would look at the use of an assisted device, whether it's a walker, a cane, whatever it may be, as something that once you give it to me, I'm going to be using that forever. And I look at it more as a tool. So if I have a patient post-op hip replacement, or I have a patient who had a history of falling or has neuropathic problems and they're having a tough time getting around, I've seen a lot of patients really push off using a four-wheel walker because they don't, whether it's the optics of it, whether it's I'm not ready to need this. I use it as a treatment. I'd rather have somebody go to the mall in the wintertime and walk around with the walker, put on the parking brakes, have a seat. You're going to be able to walk a heck of a lot more using that walker than you are without it, with the goal of working on your strength, working on your endurance, and then no longer needing it. So granted, there are people who will need an assisted device for various reasons ongoing, but there's those that don't. So I always look at those as a individual decision that's made by a team of healthcare providers, PTs, physicians, patients, families, as to what's the best way to navigate the home, the community. But I never look at them as a sentence. I look at them as a tool to become more active and engaged in the community. But making sure that you have the right assisted device and the right fit for an assisted device. Oftentimes I'll see people coming in with their walkers really high and you don't have a really good mechanical advantage, or I see people with them really low and they're leaning on them. So having that fit really, really does matter. Your home environment and home safety is huge. When we think about one of the biggest things I see is slip and falls in the kitchen, tripping on rugs, tripping on thresholds of doors. Pets are a big one. You have an unpredictable small dog and it runs out in front of you, and we don't have maybe the ability to start and stop the way that we need to. There's a lot of different things around the home that can really make a big difference. Medication use. There's some medications that will cause dizziness, that will cause fatigue, that might increase that orthostatic hypotension. We're going to stand up. Being aware of how those medications affect you. If we're changing medications, having that conversation with your physician. If it's something that you're noticing, I'm struggling with strength, I'm struggling with increased pain, I'm struggling with maybe lightheadedness. Don't discontinue a medication until your physician tells you to, but also make sure you're addressing that quickly. All of those things are things that can increase the risk of having falls. Sleep patterns and fatigue. When we're fatigued, we just, in a way, make less good decisions. Easier to have trips and falls. More difficult to catch ourselves if we do have a stumble. Step two, step one, identifying the intrinsic and extrinsic factors, right? Step two, the quiz that I've prepped you with here. This is a great place to start, just in identifying things that may be causing some problems for you individually. And then step three, communicating. Talk to your doctor about concerns that you're having, whether it's sensation, neuropathy, you're having concerns with fatigue, you're having concerns with strength, you're having concerns with range of motion. These are all things that, quite frankly, PTs, physicians work really closely with. And a lot of these problems are problems that can be solved. Very rarely are there problems with mobility that we can't make some headway with. If the end goal, is to run a marathon, we may be shooting a little bit lofty. But if we're setting the level setting expectations on, hey, one of the questions I ask patients all the time is, if we look back on this experience in 6 weeks, 8 weeks, whatever that timeline is, and everything goes according to plan, like you're happy, you're so happy, you're calling a friend and telling them about your experience, what did we accomplish? That really helps me understand your goals, right? And your goals are the most important thing. And not everybody's goals are the same. So it's important to level set that expectation with your care providers as well. At Ivy, we do free fall prevention screens. And part of that is just identifying where we may be struggling. It's sometimes I'll have people bring in footwear. Here's a bag of shoes. I've had people bring in literally bags of shoes. And, what do you recommend? Well, for these two activities, this is what I recommend. For these two activities, this is what I recommend. And sometimes it's, you have a bag of shoes. I don't necessarily recommend any of them, but here's what I would recommend. It all depends, right? So it's kind of matching the right person with the right shoe or the right exercise or the right recommendation as to which direction to go. Sometimes if we think about fall risk and we think about preventing falls, it's a big umbrella. And underneath that umbrella is a lot of different things, those intrinsic and extrinsic factors, and some of them are relevant to you, some of them are not, right? So identifying where do we start, how do we have an individualized treatment plan for every patient is in my opinion, the best way to go. And really something that I've found interesting over the years is that oftentimes a patient's idea of how their mobility is and their family's idea of how their mobility is going may not completely match up. So, and sometimes that feedback isn't really fun to hear as a patient, but it's really important. It's always kind of a hard discussion for me if I'm sitting with a husband and wife or a parent and child in an eval room. We go through the whole assessment and we're heading out into the gym to maybe demonstrate some exercises, and the child or the loved one grabs me like, here's the things they didn't tell you. So that alignment is big, right? And again, sometimes it's hard to hear, but at the same point in time, it's really good to have that well-rounded perspective of what's going well and what we're challenged with. And the fourth step, take action, being your own advocate, really thinking through like having strength deficits, being exhausted, not having the mobility that you would expect to have is not normal. So And these are all things that we can work with. If we have people who are short of breath for whatever reason it may be, oftentimes we have a pulse ox that's on them. We're keeping track of heart rates. We're keeping track of oxygen saturation. When we're moving around the clinic, we're taking blood pressure. So we're able to identify, you know what I'm noticing is when you go from this position to this position, here's what's happening physiologically. The other thing that we do with that information is feed that back to your physician. So that's part of your follow-up with them. There's more information that's being shared. And, sometimes could it be a side effect of a medication? Maybe. Could it be an effect of something else? Also, maybe. There's a lot of different variables that play into that. But really the big thing is understanding individually for you, what is the most important things to be focusing on? What are the most important things to be avoiding? And again, that individualized treatment plan. So when you take this risk factor assessment at home, maybe pick one of those tasks that you don't score as highly as you'd like to, and start there. Focus on that. So here, just as an example, hydration. It's hot outside. This is a great one to have on here today. And that may be a place that we need to start. We're going to start by really focusing on hydration. And then once we get that dialed in, create some good habits, we can move on to the next thing. Pick a simple strength and exercise and just do a few of them. Do five. Five is alive. Let's do them together. You guys are all great friends. You could have a movement challenge of some sort. That'd be a lot of fun. And challenge part of your balance. You know what I notice, if we take a step away from balance just for a moment and use kind of a parallel analogy, my 8-year-old, I watch her. We were on vacation last week, and I watched her spin around on two things: a merry-go-round and then a tire swing. And I looked at her. I'm almost getting sick to my stomach watching her. Right? It's insane how much kids can do that stuff. And I was reflecting, like, I don't do that, So as she was growing, as she was getting older, I'd sit on a swing next to her and I'd swing forward and backward. Once I'm like, nope, I'm done with that. And then I did it a couple times, and now I can swing because I'll swing next to her on a swing. And it's because I've habituated my vestibular system to not feel like that's a huge input, right? So the same thing with balance. If we are struggling with balance, therefore we stop doing things that challenge our balance, our ceiling of what we're going to be able to do keeps dropping, right? It keeps dropping the less that we do. So the more that we challenge ourselves in an appropriate way that is meaningful to us, which we could find out through that assessment, the more we know what to focus on, and it just takes persistence over time to start to develop some of those good habits and start to develop some of the really good balance related and strength related items that help us move. Okay, so we're gonna stand here in a second. I have a one more slide, and then we're gonna stand up together. So again, don't change your medications without talking to your doc. Don't think that we can't make these changes when it comes to balance, strength. We absolutely can, and don't try to go all in. And if you're noticing 3, 4, 5 things on your list, don't do them all at once. It's going to be too much. And I'm a big believer that if we're moving needles, variables of our overall function, if we're moving too many at once, you're not going to know what's really helping. And you're not going to know if we have a setback, if we're sore after a strengthening activity, we're not going to really know what it was that caused that pain. So I'm a firm believer when I'm cutting people loose with home exercises. It's not, here's 40 things, go home and do it. It's here, let's start with these 1 or 2 things that complement each other. Let's work on those. We establish a new baseline. You know what? I did really well with those. Here's what I'm noticing. Let's add a couple more that complement each other and build on what we previously did. Okay, perfect. We're doing really well with those. Let's keep on adding to this to have an individualized plan again to meet your needs. Okay, so we are going to stand up, if you don't mind. I promise I won't make this hard. All right. So all that I want you to do when you're standing, just do a little bit of a lean forward. So don't lean so far forward. So keep you're a robot. The only thing that can move is from the ankles up, and you're just going to tip yourself forward. What do you feel? what's the first thing you start to feel?
My leg. Yeah.
Okay. What else do you feel? What do you feel in the bottom of your feet?
Feet are missing a balance one.
There you go. Very good. All right, you can have a seat. That's the answer I was looking for. So
Hear what she said.
her feet were trying to balance what she was doing. So oftentimes if you're leaning forward, your toes start to dig into the ground, right? That's kind of what's keeping you from moving forward. So when we think about your first line of defense, it's your toe muscles. Your toes are gripping the earth that you're standing on, right? So if we think about the exercises that you would have expected doing leaving here today, how many of you would have thought, I'm going to exercise my toes?
Yeah.
Probably not a lot, right? But if we think about a weight shift, that's what's keeping me from falling forward, right? So if my toes don't start to dig into the earth, I would simply fall forward, right? So it's important to have good intrinsic foot muscles to help support the bottom of your feet, because when your foot hits the ground, that's your foundation of what's happening all the way up the chain. So if my foot isn't adapting to the ground that I'm on, whether it's a foot structure, whether it's strength, whether it's flexibility, we don't have a stable surface for every other muscle that we feel all the way up the chain to work on. So things I'll have people do oftentimes is just standing on the foot. Simple, whether I'm at a counter or not, I can stand here and I can challenge myself. I can go back and forth. And even that, if we think about my gait, if I was walking across this room and you took a picture of me right in the middle of my gait cycle, I'm standing on one foot, right? So that single leg stance is the midpoint of my gait. When I'm here right now, my foot's going back and forth. My foot's trying to dig into the ground. It's rolling out. It's rolling in. It's cueing everything up the chain to work. My hip is working. My hamstrings are working. Everything is working. All I'm doing is a simple single leg stance. So if I take that one step further and I close my eyes, now I'm taking my visual system out, right? So if I stand here and I close my eyes, one of the things that I'm going to start to feel is what's called a postural sway. You ever seen people on the Segways that they drive? So a Segway has a little thing in it that does that exact thing, keeps finding the center of mass, right? My brain is trying to do the same thing. So if I close my eyes, it's amazing the difference if you were to time somebody standing on one foot, eyes open versus eyes closed. Anytime I'm doing balance testing, I'm testing eyes open and eyes closed. And the reason that I'm doing that is because when we wake up in the middle of the night to go to the bathroom, our eyes are closed. Whether they're closed or open, lights are off, right? So it's important. It's important for us to know, how does our body respond, or how does our balance respond in different conditions? So I think it's important for us to test that. In some ways, it's important for us to treat that, whether we're in parallel bars, we're doing things with our eyes open and our eyes closed. It's amazing if you get to the point where you're training yourself with your eyes closed and you open your eyes, it's amazing how much different your balance is when now I have my visual input. I have what I'm now getting more accustomed to with my strength, my mobility, everything down the chain. It's amazing the difference that can make. All right, so take home message. Regardless of people's pathologies or activity levels, prior level of function, there's always room to grow. It's never too late for us to make a change and for us to improve our balance. The smallest thing, standing on one foot.
Are you sure?
You know, I will tell you, my clinical experience says yes. It does. You know, again, it's what are our expectations? You know, what are the things that we really want to work at getting back to? Sometimes it's a short runway to get there. Sometimes it's a long runway to get there. But I think the important thing is where I see patients getting frustrated is when we have that initial conversation. You know, if this goes great, what are we going to accomplish, right? And if what we're going to accomplish is going on a 2-week vacation with my family members where we're going to be on doing all these tours and walking a bunch, you know what? I think that's a phenomenal goal. Where are we now? And what do we need to do to get there, right?
Sure.
There it is. I was actually going to say that. Yeah, maybe it's because the Olympics are coming up. I don't know why. But I think it's in where I see patients getting frustrated is when they're thinking about the finish line. They're not thinking about the steps that we need to take between where we are and where we want to get to. They picture where they are now. They picture where they want to be. That gap might feel big. It might feel daunting. So you know what? I'm not going to get there. I can't envision myself getting to this point now. Well, we're not going to get there now. But what we're going to do is set up a roadmap, and we're going to accomplish step 1 before step 2, before step 3, and we're going to work our way back there. And as we're doing that, we're identifying strength issues, mobility issues, and really, again, cultivating that personalized experience for anybody to help them achieve their goals. Sometimes those goals are quite lofty, and sometimes we got to maybe say, hey, let's get here and let's reassess, and then let's get here and let's reassess to make sure that we're setting everybody up for success and realistic expectations. So when we think about balance, there's more than just balance. Again, we talked about the intrinsic factors, the extrinsic factors, when it comes to identifying what could increase our fall risk, decrease our fall risk. So balance is one of them, but all the other things, the way that we're setting up our home, the way that we're moving obstacles, the way that we're aware of pets, moving grandkids, all of those things are things that are important for us to keep in mind, not just balance, because there's so many other things that falls can result from. And a plug for Ivy, this is something that we take really seriously. The Strong Steps program was really born around COVID, when we were finding a lot of people had less mobility, they were less active, they were less engaged in the community. We were seeing far more people that were coming in that had the injuries because of falls. We had way more people that were coming in because they weren't able to interact with their community in the way that they otherwise would. So just like having a patient who's been hospitalized for honestly any length of time, like, a week hospitalization takes you out of the game. But obviously we know hospitalizations or being inactive for any length of time, so we saw a lot of people who were struggling to reintegrate in the community, and a lot of people who just kind of had the cycle. I'm less strong than I was. I'm less comfortable being out in the community than I was. And the resultant quality of life that people had and saw the decline in was really why this whole program was born. And really trying to keep people as active as they possibly can be, to be as functional as they possibly can be, to be interacting with friends and family members in their communities in ways that are meaningful for them. That's honestly a big part of our passion point. So we're happy to help in any way that we possibly can, as am I. So my contact info here, if you want more info, I'll have things to pass out. But for those on Facebook Live, my info's here. If there's anything that anybody needs, never hesitate to reach out. We're happy to help. We have 70 locations across Michigan, from the east side of Michigan to all the way to the Lake Shore, and as far north as Reed City down to the Indiana border. So we have a huge footprint where we can help people. So that's part of the fun of my job, is making sure that people have access to the care that they need. So, any questions for me? Yeah.
If you fall, what steps would you take, if you can, to put yourself standing straight?
Yeah, so that's a great question. So let's define that fall. So in that fall, did we hit the ground?
Yes, we did.
Okay. Should we make an assumption that we don't have any acute injuries?
That's correct.
Okay. So I'm going to kind of makeshift this a little bit. So if we're in our living room, we have a fall, we're safe, so we don't have any injuries, we didn't have a loss of consciousness, anything like that, right? So the first thing I would do is assess the environment that I'm in, and if there's a chair that I can get to that can help me push to stand onto that chair, and then get into a seated position. So most of the time in environments like that, there's something that we can get to, whether we're crawling to get to it, or we're making our way there. If this is a individual who had this happening frequently, devices like Life Alert are fantastic. But if this is something that if you went home tonight and you were getting out of a chair and you missed a step and you wound up on your hands and knees or wound up hitting the ground again, it's important to assess first, right? If there was something like if you had a loss of consciousness, if you had any impact to your head, if you're having any pain, that's something that we need to immediately address. So that's another thing that we need to take really seriously with falls is the secondary problems that come because of falls, right? It's not always the fall itself that's going to hurt you. It's going to be it's
Trying to get to the chair or something.
something solid. Yep, something solid. If there's someone you can call, if you're in a safe environment, I would do that. That way you can have somebody that would right. And that's so if we make an assumption that you don't, right? You don't have your phone, there's nobody there. There's no device. We're going to make our way to a solid surface that we can push ourselves up from. And again, you're going to reassess again. If you're having any pains, sometimes it's what we would envision injuries from falls aren't always the big things that we think they would be. We can have a lot of orthopedic problems because of these falls. Again, if there was an impact to the head because of the risk of bleeds that, we've had a closed head injury, but because of the risk of bleeds that aren't obvious, they're not immediately obvious sometimes, making sure that we're having those things checked out is important.
But sometimes you do get an injury, but that adrenaline kicks in and you're not feeling it.
Yeah.
You're not aware of it.
And
until later, the adrenaline comes down and you go, oh my God, all of a sudden you realize.
Yeah. That's a really good point. If you're noticing marks like, oh, I didn't even know that I hit my head. I didn't know that I hit my shoulder. I've seen that with patients often that they're active patients of mine. They've had a fall at home. They come in the next day. Were you checked out? No, I was not. Okay. So we're gonna spend some time and do that. And they have a big old bruise that they didn't even know they had. So at that point in time, we're calling their physician, hey, here's what happened. How would you like us to navigate this to make sure that we're ruling out any other pathologies that might happen? That's why I like let's take an immediate inventory. Then let's get ourselves to a chair and let's take another inventory. Once you're right, that adrenaline calms down. You're not going to feel a lot when you're in that kind of fight or flight mode, but you will later on. And that's why that follow-up is really important to make sure that we're not missing something.
I was just diagnosed with osteoporosis.
Mm-hmm.
I am currently going to IV therapy.
Yep.
For balance,
Mm-hmm.
for exercise to strengthen my muscles and stuff like that. So I feel like it's really helping. I mean, I can feel like it's,
Mm-hmm.
and I'm pretty active. I walk all the time and, do stuff. So,
what's amazing, regardless of your level of function, whether you're not used to being active or you're used to being very active, there's always ways to improve your balance and the way that you interact with your environment, right? Whether you're an athlete on a field or you're me wandering around a parking lot, right? There's always room to improve, which is why I think things like a disability, the fall risk assessment is important because something's going to show up there on pretty much everybody. But I'm glad you're having that experience, and that's the experience most of our patients have. One of the things that was said before we started is, what are you gonna have me standing on? And to be honest with you, at first, the earth. And let's see how we navigate those environments. Then let's keep adding to it. And the reason that we add to it is because if you can navigate those challenging environments, which we're emulating unstable surfaces, walking through backyards, whatever it may be, if you can navigate those things, you're so much more confident community ambulating, whether we're walking into buildings like this, or at the shopping mall, whatever it may be. If we're confident, part of it is the confidence of being able to get out and do things. And that confidence comes by really training and working through some of those issues, but really identifying also where am I struggling? Maybe I'm struggling going downstairs because of the control that it takes through my lower extremity muscles. Maybe I'm struggling standing up and taking those first initial steps because I'm struggling to control that forward momentum. But if we know, then we can start to work on those specific things. You had your hand up too.
you mentioned the toes.
Yeah.
Do you have exercises for the toe?
You know,
Something we should strengthen?
yeah, sometimes it's just it's as simple as standing at the countertop and just working on that forward and back weight shift.
Oh.
It's just easy as that. With runners, we train a forward lean. So what I'll have them do is I'll lean on a wall and then slowly try to take their hands off the wall or just lift them up. And how far forward can you get where your toes are still where your toes are still doing that without your heels lifting up and tipping forward. And part of it is you're finding that tipping point, right? And your brain does a really good job of understanding where within your base of support it can handle your balance. So the stronger my toes are, the better I am at digging in, the further I can go. But there's going to be a tipping point at which I'm going to fall forward. So if you're doing this, don't do this in the middle of your living room, or else we're going to have to revisit the how do we get back up from the floor conversation. And we don't want to have that conversation. Yeah.
If somebody chooses to do PT, do they need a referral from the doctor?
So in Michigan, we can see patients 10 visits or 21 days without a referral, whichever comes first. A lot of states in the U.S. have what's called a PT compact, where it's unrestricted direct access. If we were to go back in time, I don't know exactly which year, 5, 6, 7 years, we could evaluate, educate, and consult, but we could not treat without a referral. So where this gets kind of tricky is there's some insurances that say, hey, legally, yes, you can go anywhere you want to go, but there's certain insurances that would say we still need a referral to pay for services. So most of our patients who are coming in would be, running their care through their insurance in some way with the deductible and a copay, et cetera. Which is why our fantastic group here is good at making sure that people have the right plans for that make sense for them. So great question. Yeah.
Loss of hearing, could that affect your balance?
It can affect your balance, yes, because it can affect your vestibular system, right? So my brain's kind of a simple place, right? So I think my vestibular system's kind of like a bubble level. And as I'm moving, there's feedback in my brain coming from a lot of different ways. My vestibular system is giving me feedback. My visual system's giving me feedback. My sensory system's giving me feedback. But if my vestibular system and my hearing is affected, my vestibular system can most certainly cause those problems. As I'm tipping one way or the other, we have canals within our inner ear that help to sense motion, right? And what our brain wants is our right side and our left side to match, be equal and opposite, so the feedback makes sense. We see patients with vertigo related symptoms, right? So whether it's positional vertigo or any other types of vertigo, and what winds up happening is we get either an overactive vestibular system or an underactive vestibular system, and sometimes the right side and left side don't match. So then my brain gets confused, right? So if we think about that tire swing that my daughter was on, and that's something that my brain could not tolerate. But you're spinning around on that thing. We have these horizontal canals. So there's a fluid that's in those canals that's about the viscosity of molasses, right? So as I'm spinning around on a tire swing, that fluid gets moving around in circles in that canal. And inside that canal, there's that fluid, but there's also these little tiny hair cells. And those hair cells look like very fine hair. And as the fluid moves over the top of those hair cells, it bends them a little bit, and the receptors in the root of that hair cell can tell which direction is being bent. Therefore, you know which direction you're spinning. But if somebody were to stop that tire swing, that fluid is still moving. So that latent dizziness that you feel is kind of the current of that fluid that slowly slows down, right? When we have positional vertigo, sometimes there's a little crystal that can get into one of those canals, and it's a very aggressive. If we're used to a fluid whisking over the top of these hair cells, and now I put a rock on it, it creates a really exaggerated response where we're spinning all over the place, and it takes a minute to calm down. Oftentimes it's associated with different positions that we would get into. But hearing itself can affect things. If it's easier to be startled, it's easier to have something that is around you that you don't know is around you, and then you have to react to it in certain ways. So I don't know if that's answering your question.
Yeah.
Anything else? Perfect. I really appreciate your time. Thanks for coming, beating the heat. Thank you. Thank you. Really appreciate it. Thank you.